Good morning, everyone. We'll be getting started in about 1 minute.
Lori, it's Dave. Just want to make sure my sound's working.
Yes, perfect. Thank you.
Yep.
And Lori, it's Ellen. I hope you can hear me.
I can.
Excellent.
Thank you so much. Normally, our RPEC members are in meetings early, and I think everyone is enjoying an extra cup of coffee. People are joining kind of progressively, and so we'll have more and more folks coming in. Okay. I want to start by welcoming all of our RPEC members to today's webinar. That is hosted in part by RPEC and also our colleagues with the Healthcare Authority. For those of you who don't know me, my name is Lori Widener and I'm your Executive Director. I've been with the organization for just a little bit north of 6 months. Joining me today from our RPEC professional team is Alyssa Brady. Alyssa joined our office about 3.5 weeks ago, and so she'll be on monitoring questions today. And then I'd also like to give a shout out today to Elliot Weinstein, who represents us on the Public Employees Benefits Board. So Elliot, are you on camera? She may have stepped away from her computer. So I want to just talk with you very briefly before my colleagues begin the presentation today, and I will have them self-introduce by sharing with you that the Healthcare Authority has put together a very comprehensive presentation, and they have built in natural breaks into the presentation where they will be stopping and giving opportunity for questions to be asked by those of you who are participating today in the webinar. Both Alyssa and I will be monitoring chat for those questions. We also, Alyssa, maybe in chat you could put the email address, our general email address for RPEC. We will also be happy to receive questions by email, and we'll see how many we can get to based on each topic area. Please know that all of your questions will be addressed by HCA. I do want to share with you that the focus today is on the plan options that are available to you in the 2023 calendar year. So open enrollment begins next month. And so that's what today's webinar is all about. And so with that as kind of a context, I'd like my colleagues from the Healthcare Authority to please introduce. So Dave, would you like to begin?
Yes. Hi, everyone. I'm Dave Eisminger. I'm the director of what we call the Employee Retiree Benefits Division at the Healthcare Authority. That's the part of the Healthcare Authority that oversees and administers the Public Employee Benefits Board program, as well as the School Employee Benefits Board program. I've been with the Healthcare Authority and these programs since, in some way, shape, or form, since 2011. So I have a pretty deep understanding of a variety of different parts of the program. I've been the director of the program since 2017. Ellen?
My name is Ellen Wolfhagen. I'm a senior account manager in the Employee and Retirees Benefits Division. And I've been with HCA for 4.5 years.
And as I say, if Ellen doesn't know the answer, she knows how to track down the answer. So she's our Medicare guru, is what I like to say. Laurie, are there other introductory remarks from you?
Let's see. Only to say that we are thrilled to have this opportunity to learn more about the plan options available to our RPEC members, and we thank the staff from HCA for investing the time to share this information with us.
All right, well, we will get started. I have the first couple of slides that are kind of overview pieces, and then Ellen has the bulk of the heavy lifting. I will say that I will also, after I do my introductory, the introductory slides, I'll also monitor chat, and if there are questions that I can answer in chat while Ellen's presenting, I will do that. As well as I am familiar with what Ellen will be covering. And if there's a question I see that relates to upcoming content, I will also jump in and prompt Ellen to do a little bit more detail to address a question. So that's one of the other kind of semi-presenting, facilitating roles that I have related to trying to help answer as many questions as possible. This is a form of a presentation we've done in a couple of different forums. Ellen and I have done a little bit of a roadshow over the last 4 to 6 weeks with various organizations. So we're excited to be here today with RPEC. Our agenda today, just going through, is to have some opportunity to hear questions from you, and we're always interested in trying to understand what information we can provide or help elucidate how to find it. We have a wealth of information that the Healthcare Authority produces each year. We are in a constant state of improvement, but also making sure that people know how and where to find information. That relates to those HCA resources. That's the second bullet on the slide. We're also here to talk about the PEBB portfolio, specifically the Medicare offerings and those plan premiums as it relates to 2023. And we will do some comparison side by sides at a high level of the Medicare benefit offerings. We'll get into that a little bit later, but that is a key feature of this presentation. And then provide some insights about networks and how to find information about provider networks for the various plan options. And again, just general slide. We are in the early stages of what I call a retiree engagement strategy. Many of you may be aware of there was a proposal this past summer related to the potential future closure of UMP Classic Medicare. I want to be really clear, there is no active proposal about closing UMP Classic Medicare. There's no timeline for that. There's no discussion. There's not an active proposal before the board. But as a result of a lot of the conversations and letters and public testimony this past summer, we wanted to work with a variety of stakeholders and reach out to retirees and have an engagement strategy over the coming months and throughout 2023. And that includes understanding questions that you have in presentations like these. Ellen and some of my staff and myself have gone to conferences this past fall and anticipate that that might be a more regular occurrence in the future. We're also collaborating with a variety of organizations to plan some listening sessions in the next year. We also generally respond to correspondence and monitor themes within correspondence. And again, this is kind of a strategy and an engagement opportunity that we're looking at not only now, but throughout 2023. I do want to do a quick touch point on the Inflation Reduction Act, because that's a topic that a lot of people have heard about in the news in the past couple of months and wondering what the impacts are. There are a variety of different impacts of that legislation that are phased over a period of several years. So I want to address only today the things that are squarely set up for 2023. There's a lot of CMS guidance that's still needed for other parts of the Inflation Reduction Act and how it relates to Medicare for plan years 2024, 2025, and even 2026. But some of the more immediate provisions that we wanted to be clear about is that in the Inflation Reduction Act, there is a requirement that individual market Part D, as well as MAPD plans, and that includes the MAPD plans that are within the PEBB portfolio, will have insulin that's capped at no more than $35 per month. Now, I do want to make sure that it's to raise awareness that within UMP and the United Healthcare plans today, there's already preferred insulins that are lower than that $35 federal cap. The Kaiser Permanente plans that are in the Medicare portfolio will be transitioned to that $35 per month cap as of 2023, but already within UMP and UHC, there are lower cost options for insulin that can be covered. Also for 2023, there's a shift for covering of various vaccines. It's not all vaccines, but a good example of one to highlight is shingles will have no cost shares under a Part D plan. And then there are some changes that lower cost shares for Part B drugs. Now, Ellen's going to go over the vocabulary soup of the various Medicare offerings, but I do want to highlight here a couple of acronyms. MAPD is Medicare Advantage prescription drug. That's just a type of plan. It's a Medicare Advantage with prescription drug coverage. And then PEBB is Public Employee Benefits Board program. I'm going to highlight a little bit about some HCA resources. So first of all, we have our customer service number. It's a 1-800 number here, and it's available to reach out to staff at the Healthcare Authority, especially as it relates to eligibility and enrollment policies, but they can also help get you forms, mail you retirement guidebooks, answer just general eligibility questions, and get you information on how to contact the plan. And just if you have specific account questions about your coverage and who's covered and where to mail or send payments or billing questions, those are all things that you can access ultimately through this PEBB customer service. I will go to some questions in a few minutes. I just want to get through a couple of more introductory slides. Some additional services. Now, throughout much of the pandemic, we did not have in-person lobby services available, but we have reopened earlier this year, back in March, for in-person meetings that can help you answer questions, help you fill out forms, accept forms, even receive payments at the Healthcare Authority. Those in-person lobby services are at the Healthcare Authority's main office, which is called Cherry Street Plaza. It's in downtown Olympia, and those lobby services are available from 8 until 4 o'clock. You can find more information, also a vast wealth of information about the retiree part of the PEBB program at our general website, hca.wa.gov. And then if you have very specific questions about what a plan covers, or if a provider is accepting the plan or is a network provider, those are always best to ask directly to the plan. And there is, we have a slide that has phone numbers for the plans. And we will make sure when we're answering questions at the end that that phone number slide is up kind of permanently while we're answering questions. The next slide. Ellen, you wanted to go over a little bit about this one, right?
Yes, sorry about that. And I hope that everybody will indulge me. I have a bad cold, so hopefully you can hear me. The HCA website, as Dave said, the URL is www.hca.wa.gov. You will see that across the top there are different buttons that you can press. And if you go to employee and retiree benefits, you'll see it's bolded now because I've already gone into that. And then under that, retirees is bolded because I went into that. And what you see on the right-hand side are some quick links in the gray bar. And PEBB open enrollment is the first line of that. And that's where you would find more information about open enrollment, which occurs from November 1 to November 30th. So I just wanted to give people sort of a navigation guide to this, but I'm not going to go into specifics about it. Dave?
All right. Next slide.
If I can get there.
And we're going to pause right after slide 10 for some questions, just to give everybody awareness as to where the first pause is. So I just alluded at the end of the previous slide that there are some good questions that are best directed towards plans. And I wanted to give a little bit more examples of what those questions are that would be best to call the plan directly. The first one is really related about provider network. And there's a couple of different ways to think about this question, but the way we're trying to hopefully share and encourage people to ask the question is, does the provider accept your plan? Most of the time people think of this question as, is my provider in network? But some of the plans within the PEBB portfolio, network status doesn't matter. Your out-of-pocket payments are the same regardless of whether the provider is in or out of network. And so the real question that we encourage you asking is, does the provider accept your plan? And we really encourage that you call the plan and not just ask your provider, because this is no fault of the providers, but it's not necessarily intuitive what provider contracts they've signed, how those relate to specific plan names. And so they may accept a plan or be a network provider with a certain carrier and not realize the brand name of the product that relates to that contract. And so we've had some instances where a provider says that they don't accept the plan or they're not in network when they actually are. They just don't know the connection between the contract name that they've signed and the brand product that's being offered on the market. So we really encourage you to reach out to the plan, because the plan will be the most appropriate and will always have the most accurate information. Also, a lot of folks will check online provider directories, and while that's a great place to start, there's also some information that by federal rules under Centers for Medicare and Medicaid Services, CMS, that prevent a carrier from listing certain types of providers within their online provider directories. So the provider directory may have the good foundation of providers, but there could be providers that accept the plan that aren't allowed to be listed on those online provider directories per CMS rules. So good places to start, but we really encourage people to ask the plan because it can vary a lot. And there, like I said, all of those scenarios exist for various plans within the PEBB portfolio. Other questions to ask the plan about specific drug coverage, whether something is covered by a plan or not, and what the cost might be for that drug for either a 30 or 90-day supply. And then again with drugs, about network pharmacies and where are the closest pharmacies that are in network for your benefits. The next. This is a slide that we will show again at the end. So if you, is a good reminder that this is being recorded and RPEC's going to make the recording available after the session, also with slides. The slides will be available alongside of that recording. And we will have this slide with phone numbers up at the very end of the presentation again, if you aren't able to capture them quickly, but these are in the materials and you will have access to them after the session. And then slide number 10 before we take our first pause. This slide is really to describe, is to answer a question that's come up a lot in recent months and comes up on a regular basis with the PEBB programs. But in the PEBB program, we have what are called two risk pools, two completely different sets of benefits offerings, if you will. A risk pool really refers to how you take a population and evaluate their health factors, their age, their demographics, their utilization of benefits, and then come up with the cost and premiums for the various plans that are in that risk pool. We run two different risk pools in the PEBB program. The one that we're going to focus on the most today is on the right, the green button, if you will, and that's the Medicare risk pool. That risk pool only has retirees, and those retirees are eligible for and then enrolled in Medicare Parts A and B. The non-Medicare risk pool, which we'll spend a little bit of time, but not a lot of time today, includes all of our active employees in our state agencies, higher education institutions, and all of the employees that are part of the PEBB program, as well as our non-Medicare retirees. So those are the retirees who are not yet eligible for Medicare's Parts A and B. And one of the questions we get is, well, why are there different plan offerings between the non-Medicare retirees and the Medicare retirees? Why is there sometimes a policy proposal that is geared towards one part of the retiree population instead of both of them? This is really because state law requires the healthcare authority to treat and evaluate these two risk pools completely separately. So the bottom of this slide includes the specific state laws that set up these risk pools. So that it's not that the healthcare authority is trying to target or influence a policy only for some retirees. We're actually required to treat these risk pools differently because of decisions made by the legislature 20, 30 years ago, and just wanted to highlight that that is a feature of the program and why there are different benefits in the two risk pools, different premium structures for the two risk pools, different offerings, different policies. It's all a creature of these decisions that were made by the legislature in setting up these two completely separate risk pools. So before I turn it over to Ellen, I'm going to see if there's some questions related to this first part of the presentation.
So Dave, let me, for all of our members today who are joining us, please continue to put your questions in chat. You can also email them to council@rpecwa.org, council@rpecwa.org. So I'm going to just go through chat real quick, and we also have 2 hands raised. We were asked about the availability of this recording and also the presentation. Both will be made available to RPEC members following this presentation today. So you will have these resources to draw upon. A question came in about the listening sessions. The listening sessions continue to be under discussion, as well as additional public forums with the HCA staff. Two individuals of which are on the call today, Dave and Ellen. And we are hopeful through our work with the PEBB Medicare Coalition to work with HCA on listening sessions that would extend through 2023. You'll be receiving more information from me about the listening sessions, not only in the monthly letter that you receive from me, but you will likely also see more information in our member newsletters, which go out quarterly in the US mail. We've had a request to please not use acronyms during the presentation because it makes it difficult for members to follow. We also had a question about the acronym MAPD, MAPD. So Dave and Ellen, what does that refer to?
Yeah, and Lori, I see the questions popping up, and I've tried to address that one in real time. So that acronym again is Medicare Advantage with prescription drug. It's a type of plan structure that CMS describes as Medicare Advantage Part D, and often gets short formed in federal documentation as well as state documentation as simply MAPD. We will do our best to minimize use of acronyms, and at least we should set them up in our materials whenever they're used, but we will try to also highlight them the first time that they're used throughout the presentation as well.
Perfect. I'm going to go ahead and Alyssa, maybe you can help me with this, or Aruna, if you can unmute yourself. You've had a couple of questions, and then there are 2 other members on our meeting today who have also had their hands raised. But Aruna, would you go first?
Sure, thank you. You mentioned about Inflation Reduction Act and its impact on Medicare, and saying shingles vaccine would be covered at no cost to the retirees, people on Medicare. But my question is also the, pertussis and tetanus vaccine, along with one more disease, that vaccine is pretty expensive for Medicare recipients, and wanted to know if it is included in the Inflation Reduction Act, or is shingle is the only one? Thank you.
So, yes, that question, I did see that in there. I will have to follow up. I did not get a comprehensive list of which vaccines are covered or not covered as part of the Inflation Reduction Act. I knew that shingles would be a good one to highlight, but I'm glad to know. And if there are other ones that people are interested in, Ellen and I can follow up as to a specific list of the various vaccines, but we'll know to follow up on the pertussis one. I apologize that I don't have the comprehensive list here today, but it's good to know that that's a type of information that you're interested in seeing and we can put together.
Okay. We also have a question about the size of the risk pools and how this affects benefit offerings.
Mhm. So the non-Medicare risk pool, again, has all those active employees as well as non-Medicare retirees, has about 300 and, sorry, I'm just thinking through all of my various numbers. Let me start with the Medicare risk pool. The Medicare risk pool has a little over 100,000 covered lives. That's both retirees and eligible dependents that are covered by those benefits. The non-Medicare risk pool has about 285,000 lives. So that's employees, dependents, non-Medicare retirees, and their eligible dependents. When somebody transitions and becomes eligible for Medicare is really a pivot point in their health insurance status, really in our country. And it really sets up a very different set of rules and types of benefit offerings. So it's not really the size of the risk pool, it's really that pivot point from non-Medicare to Medicare status that comes with a whole host of new interactions with the federal government and the Medicare entitlement program. So I would say that the benefit offerings are more influenced by that Medicare status than by the size of the risk pool. Ellen, is there anything you want to add?
No, I just want to clarify that the Medicare risk pool includes only people who are on Medicare A and Medicare B. So if you have a dependent who is not yet Medicare eligible, they would not be included in that risk pool.
Until they become Medicare eligible, yeah. I also want to quickly, I see the other question, Lori, that was before that one about what kind of providers cannot be on a plan's online directory. An example of that is CMS will, so I highlighted that the question we hope people ask is, does the provider accept the plan? Because whether somebody is network status, contracted network provider may not actually change your individual experience as to how you interact with the provider or the payment of any claims. But from CMS's standpoint, if a provider has not signed a network contract, they can't appear in the provider directory. So let's say you have two providers, one named Dave, one named Ellen, and Dave and Ellen both accept a plan. Dave signed a contract, but Ellen hasn't. If the plan design is such that you're going to pay the same whether you see Dave or Ellen, you know, that's important information for you to know. You have access to both Dave and Ellen, regardless of them signing the contract. But because Dave signed a contract and Ellen didn't, CMS allows the plan to put Dave in an online directory, but won't allow the online directory to include Ellen's name. But if you call the plan can tell you that both Dave and Ellen accept the plan. So yay, CMS federal rules. But that's an example of a provider that can't be in an online directory. And it's really a creature of there not being a cost share difference when you go and make for your claims. It's to your benefit that, you know, Ellen hasn't signed a contract, but the benefit design is such that it doesn't impact your out-of-pocket expenses. But Ellen can't be in the online directory. Ellen, you want to add something?
Yes, the online directory also does not include non-Medicare providers. So for example, massage therapists are not covered under Medicare. They would not be included in the online directory.
Okay, I'd like Alyssa Brady to call upon our members who have their hands raised. Alyssa?
All right. I apologize in advance if I pronounce this incorrectly, but we have Prakash with a question. And
Hello.
you can go ahead and unmute.
Yeah,
Oh, perfect.
No, I don't have a question. I must have pushed it by mistake. Sorry.
Okay, no worries. Phil Jones, you had a question? Philip Jones?
He may have stepped away. He also put
Okay,
a
no
question.
worries.
He put a question in chat. How will Medicare's power to negotiate prescription drug prices under the Inflation Reduction Act affect premiums for each of the PEBB plans? He may have other questions, but that's what he put in chat.
So when I went over the Inflation Reduction Act slide, I highlighted that there's a variety of pieces that go into implementation in future years, plan year 24, plan year 25, and even plan year 26. The stages for what is related to this negotiating prescription drug prices for a limited number of drugs, but a set of drugs, it begins, CMS begins their journey in implementing that piece later in 2023. It won't actually impact plans for several years, and we really need to see CMS guidance to be able to answer exactly how they're going to implement things, to see what influence there could be on PEBB plans. So that's an example of a question that the Healthcare Authority really can't answer today, because we have to see how CMS is going to implement different parts of the Inflation Reduction Act. But it is something that doesn't go into effect for 2 or 3 plan years. But as we get that guidance, we'll be able to answer that question with a lot more specificity.
Okay, thank you.
Okay, and then next we have a question. We have a raised hand from Aruna.
Yes, thank you. My question was, individuals who are under Affordable Care Act on Medicaid, their financial eligibility levels are much different than for people who are on Medicare or who are 65 plus, and their financial eligibility levels are different. So it seems there was some legislation passed to put this in the last session to move forward with kind of addressing that issue, because 31 states have this regulation. Do you know where we are with it in Washington State? Thank you.
Ellen, is that a question that you might be able to tackle?
The Medicaid program is different from the Employees and Benefits Retirees Benefits Division, and I don't know the impact of Medicaid and the differences, so I would defer. We can research and get back to you, but I don't have an answer on that.
Yeah, Aruna, I think it would be best for Ellen or I to connect with you to make sure that we are fully grasping the extent of the question, the specific legislation that you're referring to from this past session. But they are 2 very different programs set up by the federal government with very different eligibility schemes, but we can do some follow-up with you on that. I'm worried that we don't quite get the full nature of your question, and that we should probably do some follow-up with you.
Thank you.
Okay, I think we've answered the questions in chat and the hands raised, so we'll turn the presentation back to HCA.
Oh,
Thank you, Lauren.
wait, hi. Hello. My name is Cindy. Can you hear me?
Yeah, go ahead, Cindy.
Yes, we can.
Hi, Dave. I'm retired from Healthcare Authority. I have a comment for Dave. Just to be clear, Medicare is not an entitlement program. We all pay into that. We pay a lot. The question I have is, does the Healthcare Authority help retirees understand that if they go onto a Medicare Advantage plan and then change back to straight Medicare, that they might have great difficulty buying a supplement because Medicare Advantage is it's considered there's a pre-existing condition. So if you don't have a regular supplement, you use Medicare Advantage, you might not be able to buy a supplement. I found that out after I retired.
So Cindy, that applies in the individual commercial market, but does not apply within the PEBB portfolio. That type of limitation, you can enroll and move in and out of any plan within the PEBB portfolio, each open enrollment. There are no such limitations within the PEBB program. So we are really on a path trying to help people understand that rule, many people have heard about that rule and they wonder why it's not highlighted in PEBB materials, and it's because that limitation doesn't apply within the PEBB retiree Medicare risk pool.
Oh, that's good to know. I did not realize that because you don't include that in your materials. So that's good to know. Thank you.
I will say it's something that it's come up so much that we don't normally highlight or regularly highlight the absence of a policy, but this one has come up so much that it's something that we very well may need to highlight as the absence of that rule in this population.
So let's take one
Thank
more
you.
question from Christine. Thank you.
Thank you. Christine Clark, Chapter 13 of RPEC. Multicare is hinting that they are moving to an ACO, as is Providence in Spokane. And Multicare is indicating that the ACO REACH program means that the insured providers are all within Multicare's corporation. And so I need some clarification on that, please.
So I would say provider networks can change really at any point. And there's actually a little bit that Ellen will go over on provider networks and influence of provider networks.
Yeah, thank you.
In a bit. And so I'm going to think about that question and tack on some additional insights once we get to that slide.
Yeah, thank you so much. I appreciate that.
Okay, I think that HCA, are you ready? You're ready to move on? Okay, thank you.
So thank you, Lori. I'm going to talk a little bit about the non-Medicare pool and what's available. So non-Medicare retirees are, as Dave said, included in the same pool as active employees, and therefore they can choose any of the plans that are available for active employees. Remember that the Medicare plans are only open to people who are enrolled in Medicare Part A plus Medicare Part B. When there is one person in the family that is on Medicare and a dependent who is not on Medicare, we call that a split account. There are some restrictions on split accounts and what plans people can be in, depending on the Medicare plan that's chosen and the non-Medicare plan that's available. And this slide lines that out by plan so that you can see what plan you can choose. These rates are for the non-Medicare retirees. And again, non-Medicare retirees do not have the advantage of an employer contribution anymore because they're retired. So the premiums are more expensive. Upon moving into Medicare, those non-Medicare retirees automatically move into the PEBB Medicare pool. This chart is sort of a simplified overview of the different plan options and what's available. So I thought I would spend some time going over this. UMP Classic is a plan that we call Original Medicare. We have Medicare Advantage plans through Kaiser. Those are sort of traditional Medicare Advantage plans. And through United Healthcare, those are Medicare Advantage plus Part D coverage, or MAPD plans. And then we have Medicare supplement plans through Premera. And if you were on Plan F, you can remain in Plan F, but Plan F is closed to new enrollments. And so we have Premera Plan G. As you can see, UMP Classic, United Healthcare plans, and Premera are all nationwide plans. That means you can see any doctor anywhere in the United States who accepts Medicare, any doctor who accepts Medicare anywhere in the United States. There is a Medicare deductible for UMP Classic. There's also a deductible for Premera Plan G. It's equivalent to the Part B, Medicare Part B deductible. There is a pharmacy deductible for UMP Classic and the PEBB MAPD plans. There is no deductible for the Kaiser plans for pharmacy, and the Premera Plan G does not include pharmacy coverage at all. So if you were to take Primera Plan G, you would have to go to the individual market to obtain a Part D plan. A standalone Part D plan is not part of the PEBB Medicare portfolio. Hearing aids, glasses, and contacts are covered by all the plans except for the Medicare Supplement plan. Medicare Supplement is really designed just to cover Medicare-approved services. Chiropractic, acupuncture, and massage therapy are covered by all the plans except for limitations under Plan G. It has to be Medicare approved. There is drug coverage of different types, but there is drug coverage on all the plans except Primera Plan G, as I said. And there's gym membership under the Medicare Advantage plans through either Kaiser or United Healthcare. This is how Medicare interacts with the PEBB portfolio. The the Uniform Medical Plan Classic Medicare coordinates with Original Medicare. Original Medicare is Medicare Part A, which covers hospital services, and Medicare Part B, which covers outpatient, specialty, and primary care services. As Dave mentioned, there were some Part B drugs that were included in the Inflation Reduction Act. That's because Part B covers things like infusion therapy that's provided in a doctor's office. Under traditional Medicare or original Medicare, the health plan coordinates payment. Under medical claims, Medicare pays primary and UMP pays secondary. Under the pharmacy claims, UMP is the only payer. Under the Medicare Advantage through Kaiser, that covers all of original Medicare. That's Medicare Part A plus Medicare Part B. And it's an option for retirees seeking additional services, and it offers creditable drug coverage. Creditable drug coverage is at least as good as Part D drug coverage, but it may be better than, and it has different tiers and different levels of copays. Medicare Advantage plus prescription drug coverage plus Part D, which is the MAPD United Healthcare plans, cover all of original Medicare, plus Medicare Part D coverage, which means that the offering is controlled by CMS, the formulary and the tiers and the copays. The United Healthcare plans can receive federal subsidies of up to 75% of the cost of drugs to offset the Part D costs. And these plans are employer group plans. This is very important. These are very different than the individual market plans. These are employer group plans which allow for customization of benefits and the formulary. And finally, the Medicare supplement plans. These are sometimes called Medigap plans. They're intended to cover the gap that Medicare doesn't cover. Medicare, original Medicare, pays 80% of the services, and Medigap plans cover the other 20%. So you have no out-of-pocket costs. They do not include any drug coverage. To give you an idea of how all the different programs work together, across the top we have the plans, UMP Classic Medicare, then the Kaiser plans, then the United plans, and then Primera. All of these plans receive an explicit state Medicare subsidy of $183 or 50% of the premium, whichever is less. Medical under UMP Classic coordinates with Original Medicare. Medicare Advantage which is sometimes called Medicare Part C, because it includes Medicare Part A plus Medicare Part B, so that makes it Medicare Part C, and managed care. That's what makes Medicare Advantage Medicare Part C. The Kaiser plans and the United plans receive all of that. And the Premera plan, again, helps to cover the out-of-pocket costs that are not covered by original Medicare. In terms of pharmacy, UMP Classic Medicare and the Kaiser plans all offer creditable drug coverage. Again, creditable drug coverage is at least as good as Part D coverage, but it may differ in terms of copays and tiers. The United plans offer Part D coverage, and again, Premera offers no drug coverage at all. Here are the premiums for 2023. The plans are the first column. The second column is the monthly premium, and the last column is the annual cost of that premium. These premiums are after the explicit state Medicare subsidy of $183 or 50% of the premium, whichever is less. If there is a subscriber and a spouse, both Medicare eligible, then the cost would be double the monthly premium less $5, which is added as an administrative fee. And I'll leave this up for just a minute. I'd like to talk just a bit about managed care versus HMOs. Medicare Advantage plans, as I said, are sometimes called Medicare Part C, which is Medicare Part A plus Medicare Part B, and managed care. Managed care means coordination of care to ensure that the member gets case management and the right care at the right time. HMOs, or health maintenance organizations, are closed network types of plans. In our portfolio, the Kaiser plans are the only plans that are HMOs.
Ellen, I think we're going to pause for questions.
I was just going to say that.
Mm-hmm.
And we actually have quite a few that are in chat. So, okay, let me see here. Going to make it nice and big so I can see it. One moment, please.
Lori, while we do that, I think I'll go back to the premium slide just so that it's up for folks.
And actually, I'll go ahead and answer kind of the last question first while you're pulling those up. The last question in this series was about the subsidies that are in play, who pays the subsidy. And so it's a good slide to talk through that right here. There are, and please ask follow-up questions, because there's multiple types of subsidies that come from multiple places. And so I have to walk through it myself several times just to make sure that I hopefully say it the right way. But the first subsidy that I'll talk about is a subsidy that comes from the state of Washington that the legislature sets. That's the subsidy many people are familiar with. We call it the explicit subsidy. It's set in the state operating budget each biennium and can be adjusted in future fiscal years for what that value will be. It's currently, and it's been set this way for a couple of years now, it's set as $183 per month or 50% of the premium, whichever is less. And so again, that's $183 or 50% of the premium, whichever is less. And that is, it's an amount that is directly transferred to the healthcare authority on behalf of retirees and enrollment, and we put into the calculation in producing the monthly premium. So the monthly premiums you see here on this chart already reflect the state's explicit subsidy contribution. Now, that $183 or 50% of the premium, whichever is less, the only plan I believe right now that there's two plans that have where the retiree experiences the full value of that $183. That's UMP Classic Medicare, the one where the monthly premium here is $438.34. And then also Premera Medicare Supplement Plan F Disabled, where you see $196.69. Those two premiums reflect the full $183 being realized. The rest of the plans, the value of the subsidy that's received is 50% of the premium. Now, if plan costs go up, that could, more subsidy will be realized. But as it stands today, 50% of the premium is covered for everything that's not UMP Classic and the Premera Medicare Supplemental Plan F Disabled. That subsidy is paid by the state. Its funds transferred directly to the healthcare authority to offset premium costs for retirees. Now, there are other subsidies at play that come from the federal government. And one of the questions that often comes up in this particular slide is, we can see very clearly there's one plan that is much more expensive than all of the other plans, and that's UMP Classic Medicare. And the question is, why? The federal government, under federal statute or federal law passed by Congress and then implemented by CMS as part of the Department of Health and Human Services, has specific funds that plans are eligible, but they've got to meet certain requirements. And as it currently stands under those various definitions, and the UMP Classic Medicare cannot qualify for those federal funds. But the rest of the portfolio, all of the other plans, do meet the requirements under federal law to qualify for these really substantial subsidies that the carriers receive that offset and lower premiums. And so that's a different kind of subsidy. It's a subsidy that's paid by the federal government directly to the carrier. So in this instance, directly to Kaiser, directly United, directly to Premera, and it lowers the cost that ultimately results in the monthly premium that is then paid by an enrollee. But UMP Classic is not a plan that is eligible under federal law to access those same federal subsidies. So that's a little bit on subsidies.
Okay, so let me address some of the questions. The first one is from Aruna. How can we have parity between Medicare Advantage plans and supplemental plans?
Can I ask Aruna to give a little bit of clarification as to what is meant by parity in that question?
Sure. What Medicare Advantage plans do is they pay for, say, membership to the gym. Also there have been Medicare Advantage plans that have additional coverage as far as vision and dental, those kinds are limited, but they have those coverages which Medigap plans don't have. So I just wanted and Kaiser covers also for massage and acupuncture, etc. Whereas we don't have that coverage in Medigap because Medigap only pays for whatever original Medicare pays for. So there are many advantages that are, it seems more and more consumers are pushed toward going and enrolling in Medicare Advantage plan. And that's the reason the parity is important, because in case of Medicare Advantage, there is often denials and delays in approving the treatments that the subscriber needs. Thank you.
Thanks, Aruna. I thank you for clarifying that. That really is helpful to, because as I understand your question, is there something that's preventing Medigap plans like Supplemental F or Supplemental G from having those additional types of coverage that are existing in other types of plans, and or what would it take for there to be parity or allow Medigap plans to have that type of coverage? Ellen, I don't know if that's something that you can speak to a little bit. I think that I've heard you speak a little bit to that question in the past.
So it's really about the structure of the plans. Medigap plans, as Aruna said, are meant to cover original Medicare services. So Primera, as one of the providers of those kinds of plans, has other plans available that cover those additional services, and there's a higher cost involved in them. But as a Medigap plan, it is limited by definition to Medicare covered services.
Yeah, so Aruna, one of the things that happens at the federal government, and many of us are aware that there's an alphabet soup of Medicare offerings. There's Part A, Part B, Part C, D, E, F, G. There's like every letter of the alphabet, it seems at this point, and they all have strict definitions, many of which relate to benefit design. And in order to, and the federal government did this to help try to standardize offerings so that if people looked at Plan Fs, they knew that everything they looked at that was labeled Plan F had the following features. And if they looked at something called Plan G, they had the following features. So there are strict definitions as to what is covered or not covered in order to qualify for that letter of the alphabet, if you will, by CMS. So it's not that there, as Ellen said, that there aren't other plan designs that could have those pieces, but a Plan F or a Plan G by definition has a specific benefit structure in order to be called and marketed as an F or a G plan.
But it seems, thank you for that clarification, but it seems there is a movement to push the subscribers from Medigap plans to Medicare Advantage plans. And as we get older and live longer, we have more health issues. And Medicare Advantage is usually set up to meet the needs of people who are lower health risk versus higher health risk. So as a consumer, it is to my benefit as I'm getting older to be on a Medigap plan. But the services are limited. So there is a need for some advocacy in that area too. Thank you.
Thank you, Aruna. Let me pick up the next question. It's from Elliot. On the CMS website, it says that their goal is to place all Medicare members on Medicare Advantage plans by 2030. How does this impact plans F, G, and UMP?
The best I can answer that question, Elliot, right now is that, you know, there's nothing from CMS that has, you know, closed Plan G for enrollment. I mean, if CMS went forward with various policies to effectuate that goal that they've stated of increased or total Medicare Advantage plan enrollment, they would have a variety of different regulatory tools in their toolbox to either limit enrollment or incentivize enrollment or shift enrollment or close plans. Those are all things that are always possible within the CMS world, but none of that has, you know, none of that policy making has actually occurred. So at this point, it's a stated goal of CMS, but there's nothing that specifically excludes, disincentivizes, transfers enrollment, closes enrollment in any of those types of plans that you've highlighted. So at this point, there's nothing that directly connects an impact on FG and UMP to that CMS stated goal. But that doesn't preclude such action by either CMS or Congress or the Department of Health and Human Services to make progress towards their stated goal.
Another question that's related comes from Elaine. Why is the government pushing people towards Medicare Advantage private insurance? I think that Dave talked a little bit about this. It was highlighted in Elliot's question, relates to what Aruna said. Aruna's final comment about the need for federal advocacy. Absolutely, we couldn't agree more. Dave, do you want to respond to that question?
I'll do the best. I mean, I can't speak for Congress, but I could speak about what's been said about what Congress was intending. So Medicare Advantage was set up roughly 2 decades ago at this point. And at the time, the policy position that was postured for the creation of Medicare Advantage was to create a private sector kind of alternative to traditional Medicare, if you will. And it was seen as a way to encourage innovation within Medicare offerings to drive lower costs at better care. Now that's kind of like the talking points from 20 years ago at a high level, but that was the idea, was to create this financial incentive for carriers to be innovative and hopefully drive down costs within the overall Medicare population as it was being treated. Now, I know that there's a lot of views as to whether that policy stated goal is being achieved or not achieved, but that was kind of the rationale behind the creation of Medicare Advantage at a really high level. And I will say that we are working on some correspondence to our federal partners, our congressional delegation. This is something that I've committed, for the agency's committed to working on, and Lori has asked questions of before. We're working on it this fall about what exactly that earlier I highlighted how the UMP Classic Medicare is not eligible for various federal subsidies like the rest of the plans. We're working on describing what we believe it would take by Congress to make such subsidies available, and then we'll make sure that stakeholders, including RPEC, are aware of that for federal lobbying efforts.
Thank you. Okay. We've had a lot of questions about the subsidy, which were answered. Claire, was your question answered regarding the UMP drug coverage under Medicare Part D?
Actually, I think it was answered on the next slide.
Okay, so good, you got that covered. We have a question and I'm not looking at the screen at this time because I'm monitoring chat, but there's a frame that you shared that identifies which plans are HMO and which are managed care. So if that isn't already up on the screen, that might be helpful for folks to take another look at that.
Ellen,
Lori, if I can, Lori, if
Yes.
I can. Just the Kaiser plans are HMO plans. None of the other plans are HMO.
Thank you. So I want to, there's a question in here from Matt. Okay, and this has to do with comparing the complexity of the different plans, and Matt asks, you know, where do we go to get expert help, or are we on our own? I know that there's a frame that HCA put up earlier that has the different plan contact information. Later in the presentation, I believe that I asked Ellen and Dave to talk about the resources that are available through HCA and the support that they're able to provide. So I think they're going to circle back and cover that once again. But
yeah,
there is
Lori,
information in the document.
I'll also add in, I'm working on a comment and a link. The Healthcare Authority every year produces what we call a comparison chart, and it has lined up all of the plans side by side, and it goes on for about 4 or 5 pages. It tries to balance high level concepts with also going, you know, into a little bit deeper dive, but we do set up this comparison. And in fact, Ellen's slides later will start to do a comparison of UMP with another plan and goes through a comparison of each plan side by side with UMP. But there's even more detail in this comparison chart. Our 2023 version for the plan year 2023 was just published within the last week, but I'm going to put that link in here, and it's a really helpful resource that we put together to try to answer this exact question that you raised.
Okay.
I also have a slide of it.
We also have a question from Brian. So if I were to switch from Premera to United Healthcare Advantage plan, can I switch back to Premera in the future without worrying about questions of pre-existing conditions?
Yes. So thanks, Dave. That's one of the benefits of being in PEBB. Because in the PEBB portfolio, during open enrollment, you can switch from any Medicare plan for which you're eligible to any other Medicare plan for which you're eligible. And the only reason I say for which you're eligible is the Kaiser plans have geographic restrictions. Those are the only plans. Again, those are the only plans that are HMO. Those are the only plans that have geographic limitations. But yes, you can switch from, for example, Plan G and go into one of the Medicare Advantage prescription drug plans, one of the United plans, and then the next year switch back. You can switch to United Uniform Medical Plan, Classic Medicare if you want. So you can switch during open enrollment from any Medicare plan to any other Medicare plan for which you are eligible.
So this is a follow-up question. It's a little bit different. If this is from Christine, if you choose the Medicare plan that it's not listed here in your presentation, can you ever return to a retiree Medicare plan through PEBB?
That's an excellent question, and that's a point that we really have to highlight. If you choose an individual market plan that is not an acceptable deferral reason for not taking your PEBB retirement, and you would lose your eligibility to come back to PEBB retirement. So it's very important, if you don't want to take PEBB retirement at this point, to understand what plans allow you to do that and how you can successfully defer your enrollment in PEBB retiree coverage. But please be aware that if you just choose an individual market plan, that you will lose your PEBB eligibility. And I know that we've in the past had people who unfortunately made that choice through a mistaken belief and have had to suffer the consequences. So it's very important to understand that. Thank you for the question.
Okay. So we've been asked by Vela, what is the difference between Medicare retired and disabled? What if you are both?
If you are age 65, which is what Plan G calls Medicare retired, then even if you are disabled, you're under the Medicare retired coverage. The disability is really early qualification for Medicare because you have not yet reached 65, but you have a disability which CMS recognizes and allows you to access Medicare coverage.
Okay.
Lori, I
Yeah.
think in
Yeah,
interest of time, I'm going to move on
okay.
because I'm
We
afraid.
will. I think that's a good call. And of course, we can circle back to some of these questions and we'll get them answered.
Absolutely. I just want to, we have a lot of information. I want to be sure that we have a chance to go through it. So I'm going to do a deep dive between the individual market. And again, this is a perfect follow-up to that question. Please be aware that the individual market plan does not qualify as a retiree coverage that allows you to defer PEBB coverage. So, you know, part of the reason is that we work very hard in the PEBB portfolio. We have a very large market basket, and we can negotiate with the carriers for benefits above and beyond what's available in the individual market. So here are some differences between United Healthcare, which is the most common individual market carrier, and the PEBB group sponsored Medicare Advantage prescription drug plans that we have in the PEBB portfolio. So first of all, most of the commercial market, also known as the individual market, most of those plans, usually AARP branded plans, are HMO plans. Our plan, both of our plans are PPO, any willing Medicare provider. The maximum out of pocket, this is a huge difference. The maximum out of pocket for in-network expenses runs between $5,000 and $6,500. So the way that those individual market plans work is it's usually a zero premium plan. So you're not paying as a premium every month, but you pay every time you go to the doctor. And your out of pocket protection, your upper limit, your cap is very high. On PEBB Complete, the out of pocket maximum for medical expenses is $500, so 1/10. For PEBB Balance, which balances having a slightly lower premium with some expenses every time you go to the doctor, has a $2,000 medical out-of-pocket maximum. As I said, copays a lot of times may be $0 in network for the individual market, but out of network, there's $25 costs. PEB Complete is $0 for primary care. PEB Balance is $15 copay for primary care. And those copays are whether the provider is in network or out of network. There is no difference in copays in the PEB MAPD plans. For specialty tiers, this is where the individual market gets a little more expensive. Primary care is $35 to $45. Again, it's $0 in PEB Complete and $30 in PEB Balance. No difference between in-network and out-of-network. And out-of-network can run as much as $65. The pharmacy deductible is $225 on the individual market. You will see it says tiers 3 to 5. If you've paid attention, you'll know that there's only 4 tiers when we talk about the PEB MAPD plans, the Part D plans, and the tiers. It's because different plans have different tiers, and to equalize everything, we had to create a extra tier. For example, in the PEB program, we have preferred insulin at $10, which is different than anything else. The pharmacy deductible for both the PEB Complete and PEB Balance is $100 for tiers 3 to 5. The maximum out-of-pocket, again, this is a huge difference and something to pay attention to. On the individual market, there's no out-of-pocket maximum. So you have no protection. There's no cap that you stop paying at a certain point. On MAPD plans under PEB, that limit is $2,000. And you may be aware that the Inflation Reduction Act is targeting that $2,000 limit as well. Some people may know about what's called the donut hole or the coverage gap in Part D coverage. That's where your copays increase and you have to start paying a much higher percentage. Generally speaking, on the individual market, it's 25% of the cost of the drug, and that's of the total cost of the drug. But under the PEB MAPD plans, and again, this is a factor of these being employer group plans. This is specifically negotiated. Under our plans, under PEB, you just pay the applicable cost share for whatever tier for the entire year. You never reach the coverage gap. So the key differences, as discussed earlier, you can change your plans without concern about pre-existing conditions or needing a medical exam. In PEB, you can change your plan every year. HCA administers the eligibility and enrollment, so the carriers cannot simply drop a PEB retiree, nor can they change the retiree's coverage without having gone through different rate setting with HCA. And our contract teams manage the contracts very actively, and we can intervene with all the carriers to ensure that they achieve the contracted levels of customer service, as well as we can intervene in terms of coverage questions, billing questions, or prescription drug coverage questions. Now I'd like to give some insights on the provider networks. HCA does not do direct provider contracting for PEB, so even for UMP, the provider networks are controlled by the carriers. So in terms of UMP, that would be Regents for medical services, MODA for pharmacy. Kaiser does their own contracting, whether it's Kaiser Northwest or Kaiser Washington. Those are actually 2 separate companies, or United Healthcare, which is known as UHC. Providers can join or leave a network as long as they provide adequate notice. And you may have heard there's some stir that's going on with Providence. I know that it's affecting some contracts in various areas. And HCA cannot require a provider to stay in network even through UMP. So there are changes that providers are allowed to make. As Dave said, the most important thing to ask the plan is, does my provider accept your plan? I'm going to leave this slide up for a minute. The phone numbers are generally the same as the phone numbers that we will show again later, and we will keep up. And there are websites for finding provider directories. As Dave said, sometimes providers are not listed on the provider directory, so you might want to call the plan and specifically ask if they're included. As another reminder, the Kaiser Northwest and Kaiser Washington plans are HMO plans. They have a specific network. They may not provide out-of-network coverage at all, and it's important to find that out. The other plans are PPO or Preferred Provider Organization plans. That means they have any provider who takes Medicare and is willing to accept the plan. These are some considerations that should be taken into account when making a decision on healthcare coverage. Healthcare coverage is a very personal decision. We cannot advise you what to do. It's personal to you. But we want to be sure that you have information. So the kinds of things that you want to think about are the coverage, what's available, what are the benefits, the costs, not only the monthly premium costs, but out-of-pocket costs, changes in network if there's any differential, and the limits on prescription drug coverage. And another consideration is how comfortable you are with the plan. Some people are very comfortable with their plan and don't want to change, and that's fine. You know, there's certainly nothing wrong with saying, I'm really comfortable with what I have. And finally, convenience. It might make more sense to be in a plan with a limited network if you have great access to facilities and providers relatively close by. And it might not make sense if you live in a rural area, for example, where there might be limited facilities. As Matt Groshing said, you know, there's a lot to compare all the plans. This is a snapshot, and I apologize, I know it's hard to read, but this is a snapshot from the Retiree Enrollment Guide, which will be sent out at the end of October prior to open enrollment. So everybody will receive one. And this is the comparison of the Medicare portfolio. So this covers things like the deductible, the medical out-of-pocket maximum, the prescription drug deductibles, the prescription out-of-drug limitations, ambulance, emergency room, hearing aids, and vision. Now, it's important to note that this does not cover every eventuality of types of services that you might encounter. This is a summary, and you can see that there's a lot of information on this one page, but it does provide a snapshot that allows you to compare across the different plans how an individual service would be treated under those plans. Again, the kinds of questions that you might ask a plan include things like, I'm expecting to have, maybe I have a cancer diagnosis and I'm expecting certain kinds of infusion therapy or certain kinds of drug therapy and want to be sure that it's covered. You're not going to find that in a chart, but you can call the plan and ask specific questions. As Dave mentioned, I'm going to do a comparison between UMP and each of the other plans that are available in the PEBB portfolio. The reason that we're using UMP as the comparator that is the plan that's been chosen by more people than any other plan. So it makes sense to say this is the base and here's the comparison. If you are not in UMP, that's fine. You can look at the general chart and see how your plan compares to other plans. But I will provide information on each of the plans. I'm going to start with Primera Plan G. You will see that there are only medical services on this chart. That's because, again, Plan G covers only Medicare approved medical services. So the deductible in UMP is $250. The deductible for Plan G, which is the Part B deductible under Medicare, has just been set by CMS at $226 for plan year 2023. For anybody who was in Plan G last year, it's a slight reduction. It's $7 less than it was last year. All of the other medical services here you can see under Plan G, you don't pay anything for. Again, the purpose of Plan G is to cover what Medicare does not cover and make sure that people don't have out-of-pocket expenses. This is a comparison with KP Northwest, that's Kaiser Permanente Northwest, which is available only in Southwest Washington, kind of ironic. KP Northwest has a plan called Senior Advantage. It is a Medicare Advantage HMO plan. And this is how it compares to the Uniform Medical Plan Classic Medicare. For the deductible, it's $250 under UMP. It's $0 under Medicare Senior Advantage. The out-of-pocket maximum is $2,500 under UMP. It's $1,500 under Senior Advantage. This is per person. Inpatient services, $200 per day per admission. So if you go to the hospital 3 times in a year, you would pay at least $200 per day times 3. Under Kaiser Senior Advantage, it's $500 per admission. So again, if you went 3 times, you would pay that times 3. Outpatient services, you will see that UMP has a lot of percentages. That means it's co-insurance, and that's a percentage of the total fee for that service, and is not necessarily a predictable amount. For Senior Advantage, those are co-pays. Co-pays are set dollar limits, so you know in advance how much you'd be paying. Outpatient services are $50 under Senior Advantage. For mental health, there's a $30 charge for individual therapy, $15 for group therapy under Senior Advantage, and 15% under UMP Classic. Primary care visits are 15% under UMP Classic, $30 under Senior Advantage, and that's the same for specialty care. Urgent care is 15% copay, and Senior Advantage is $35 if you go to the office, $50 if you go to the ER. The ER copay is $75 under UMP Classic plus 15% copay, and under Senior Advantage, it's a $50 flat copay for ER. This slide shows supplemental benefits. This is something that the Medicare Advantage plans offer. These are supplemental benefits approved by CMS. They're also offered under UMP Classic. They include chiropractic care. Under UMP, it's $15 a visit for up to 24 visits in a year. Under Senior Advantage, it's $35 per visit, up to 12 visits per year. Acupuncture under UMP is $15 for up to 24 visits. And under Senior Advantage, it's $35 up to 12 visits a year. Massage therapy is $15 under UMP, up to 24 visits in a year, and $25 under Senior Advantage, up to 12 visits a year. Routine vision exams and hardware. So I just want to make a note. Medicare covers medically necessary eye exams, but not routine eye care. Under UMP Classic, it's a $0 annual exam with a $30 copay for contact lens fitting. And there's a hardware allowance of up to $150 every 2 years. Under Senior Advantage, the annual exam is $25. Again, this is a routine annual exam. And the hardware allowance is up to $150 every 24 months. Routine hearing exams and hearing aids. Again, Medicare covers medically necessary hearing exams, but not routine care. Under UMP Classic, it's $0 with an annual exam, and the hardware is covered 1 per ear every 5 years. Under Senior Advantage, there's a $35 annual exam copay, and you're allowed up to the annual amount 1 per ear every consecutive 60 months. Just to translate, 60 months is 5 years. Under UMP Classic, gym membership is not covered. And under Senior Advantage, it's covered as Silver and Fit for $0 copay. This is how the pharmacy benefits compare between UMP and Senior Advantage. Again, UMP Classic has a $100 pharmacy deductible. Senior Advantage has $0 deductible. The maximum out-of-pocket limit for UMP Classic is $2,000. There is no limit on Senior Advantage. And again, as I said, the tiers are different. Different plans have different tiers, and UMP has what's called a value tier, which really exists only in UMP. Tiers are just classifications of drugs, different levels of copays for different kinds of drugs. The plans have some flexibility in how they determine those. But generally speaking, generics are covered at 10% of the cost up to $25 for UMP Classic, and that level is $20 under Senior Advantage. Preferred brand names are covered under UMP at 30% up to $75, and under Senior Advantage at $40. UMP Classic does not have a tier 3 for non-preferred brand names. Those are generally covered under generics. And they do not have a tier for specialty drugs. Those are generally covered under tier 2 preferred brand name drugs. And you will see that under Senior Advantage, those are covered 50% up to $200 for both of those tiers under Senior Advantage. It is important to understand that there are geographical limitations because Kaiser plans are HMO plans. They are limited in the network and they are limited in the service area. Kaiser Northwest, which is abbreviated KPNW, has these counties in Washington: Clark, Cowlitz, Skamania, and the zip codes 98612 and 98647 in Wahkiakum. They also cover a number of counties in Oregon. And again, you can see that in your materials. This is Kaiser Washington, also abbreviated KPWA. KPWA. Their Medicare Advantage is known as Medicare Advantage. So again, there is no deductible for medical. The maximum medical benefit out of pocket is $2,500 in UMP Classic and $2,500 in Kaiser Medicare Advantage. And again, the big difference is that there are copay limits, so flat fee limits under Medicare Advantage, and there are co-insurance numbers under UMP Classic. In the interest of time, I don't think I'm going to go very specifically over the rest of these. When you get these materials, you'll be able to compare them. In terms of the pharmacy, again, there is no out-of-pocket limit for Senior Advantage. There's also no deductible. Kaiser does not have a value tier. The generics are covered with a $20 copay. And it's important to note that you always pay the lesser of the actual cost or the copay. So the copay is a maximum. Preferred brand names is a maximum of $40. Non-preferred brand names is 50% or $250. And specialty drugs usually require an exception with Kaiser. They have to be treated as a different kind of program. You have to get permission, and they are generally covered under Tier 3. These are the Medicare Advantage service areas for Kaiser Washington. These are the Washington counties only. Where there are numbers, those are zip codes because the plan is available only for specific zip codes in those counties. But generally speaking, Grace Harbor, Island County, King County, Kitsap, Lewis, Mason, Pierce, Skagit, Snohomish, Spokane, Thurston, and Whatcom counties. This is a comparison between UMP Classic and PEBB Balance. UHC stands for United Healthcare, that's the carrier. So UHC PEBB Balance, there is a $0 deductible. Again, the medical maximum out of pocket is $2,500 under UMP, $2,000 under PEBB Balance. The inpatient services is $200 per day per admission. Under PEBB Balance, it's $500 per admission, regardless of the number of days. Outpatient services is again $500 per admission. Outpatient mental health, there's a difference between group coverage and individual therapy. It's $15 for group therapy, $30 for individual. For primary care visits, again, the copays under UMP are percentages of the actual costs. The primary care visit under PEBB Balance is $15. Specialty visit is $30. Urgent care is $15, and ER copay is $65. Under chiropractic, you can see that it's $15, 24 visits for both UMP and PEBB Balance. Same for acupuncture, and then for massage therapy, it's $15, 24 visits limit under UMP Classic, and it's $15, 30 visits maximum under PEBB Balance. Routine vision is $0 for the annual exam, including a contact lens fitting, and the hardware allowance is up to $300 every 2 years. For routine hearing and hearing aids, the exam is $0, and the hardware, again, is covered one per ear every 5 years under UMP. Under PEBB Balance, it's an allowance of up to $2,500 from United Hearing, which is their network for different kinds of providers for hearing aids, and that's every 5 years. Gym membership is covered under a program called Renew Active under PEBB Balance. Renew Active is what used to be called Silver and Fit. They just changed the name. I noticed that people are making lines on my document, so I'm not quite sure how that's happening, but I would appreciate it if you could maybe refrain from marking the document. So the comparison with PEBB Complete, you can see that the maximum out-of-pocket for medical expenses is $2,500 under UMP Classic. It's $500 under PEBB Complete. The only copays that you have under PEBB Complete are urgent care and ER. It's $15 for urgent care, $65 for emergency room. The supplemental benefits, again, chiropractic, acupuncture, and massage therapy also all have $0 copay. The limits under chiropractic and acupuncture are 24 visits. The limit under massage therapy is 30 visits. And again, routine vision and hardware. The routine vision exam includes contact lens fitting, and the hardware is an allowance up to $300 every 2 years. Routine hearing is, again, hardware 1 per ear every 5 years for UMP Classic. And it's limited, the hardware allowance is limited under under UHC, under United's PEBB Complete. It's limited to up to $2,500 from United Hearing, which is a network, every 5 years. And again, gym membership is covered under Renew Active. Lori, can I ask that people be muted, please? Thank you.
Yep, you bet. Thank you.
This slide includes the pharmacy plan for both United PEBB Balance and United PEBB Complete. And the reason is that those plans have the exact same pharmacy benefits, and so there's really only a need to show it once. The pharmacy deductible is $100 for tiers 2 through 4, so 2, 3, and 4. Again, these plans include Part D coverage, so the tiers are set actually by CMS. It determines which types of drugs go into which tier. There is no value tier, but again, as I said, there's something like preferred insulin at $10 a month. For generics, the copay is up to $5 per month. And I do want to note for anybody who was on the MAPD plans, the Medicare Advantage plus prescription drug plans in year 2022, those plans did have percentages. They had coinsurance, and in 2023, they're moving to copays. So these are the 2023 copay amounts. For tier 2, which is preferred brand name, it's up to $45. Again, one always pays the lesser of the actual cost of the drug or the copay. Non-preferred brand names, it's up to $100. And specialty drugs are up to $100. I apologize, there should be a note on this. Specialty drugs are limited to a 30-day supply, regardless of where you get them, whether you get them at a retail place or through mail order pharmacy. And there is a difference this year in mail order pharmacy for these plans. It instead of, you get a 90-day supply for the cost of 60 days or 2 times the 30-day copay, but you get 90 days if you do it through the preferred mail order pharmacy. And finally, before we move into questions, I know that a question that comes up very often has to do with worldwide travel. We are very lucky in that we have a lot of retirees who have the opportunity to travel for part of the year, and a lot of them live out of the country for part of the year, and that's just wonderful. So just a note on Medicare and international services. Medicare does cover emergency services, even if you are traveling internationally. So all of the plans cover those because Medicare covers those. But for non-emergency services, we only UMP Classic and the United Healthcare MAPD plans cover non-emergency services, and those are covered on a reimbursement basis. So non-emergency is you're sick, but not so sick that you need to be in the hospital, for example. You just want to see a doctor or consult a doctor. So that's non-emergency services. And I think at this point, Lori, it's good time to take a break and answer questions.
Perfect. There was a question posed in chat, which Dave answered, but I think for those who aren't monitoring chat, I'd like a response from HCA. The question was about whether a member and a person's spouse could enroll in differing plans during open enrollment. So can you respond to that, please?
Yeah, in general, the answer is no. There's one exception. That's if one of you is Medicare age and one of you is non-Medicare age, then you would be what Ellen described at the beginning as a split account, and you would be under a non-Medicare offering for the individual who's non-Medicare, and then you'd be under a Medicare offering for the individual who's Medicare. But if you're both Medicare, as the question was in the specific answer, you have to be enrolled in the same plan. And the structure of the PEBB program is that there's a single subscriber who owns the account, and then everybody under that account is under the same, is enrolled in the same exact plan. Again, except in the split account scenario where one of you is not Medicare and the other is Medicare. Ellen, what else do you want to add?
So thank you, Dave, for reading my language. There is another exception if you both have individual PEBB eligibility. So for example, I am a state employee, my husband is a state employee. We are both entitled to PEBB benefits separately. I do not have to be on the same plan with him. I can choose to go under my own plan, under my own eligibility, but I have to have independent eligibility.
So we had another question about eligibility, and that's probably a helpful response. There may be some members, RPEC members, who were on our webinar today who aren't sure if they're covered by PEBB. How would they verify that? Could you speak to that briefly?
Yeah, there's, Ellen, I'll answer how I answered in chat, and then you can add on. The pieces I put in chat are, you could check our online enrollment account. It's called PEBB My Account, and I have the link in chat, and I can put it again if that would be helpful. And you can sign into your account and see your current coverage, or you can call our 1-800 number, 1-800-200-1004, and speak with a customer service person at HCA, and they'd be able to confirm any current enrollment that you or others have. Ellen, what would you add to that answer?
I would also say if you look on the HCA website, there's information about how you qualify for PEBB. And if you meet that criteria, so you can go through, there's sort of a checklist you can look at and go through.
Okay, this was answered in chat, but again, for the benefit of those who aren't monitoring chat, can you explain why the PEBB portfolio has a restricted number of choices?
Yeah, and for folks, I wasn't sure how time was going to go, so I wanted to get as many answers as I could. So glad that we have time to bring unearth some of these into the actual verbal presentation. So the question is generally about plan choice, and there's a couple of ways to think about this. There are 5 different carriers, if you will. I use that term loosely because technically Uniform Medical Plan isn't a carrier, but there's 5 broad entries. The Primera plan, 2 United Healthcare plans, the Uniform Medical Plan Classic, and then there's 2 regions of Kaiser that are HMO. And a variety of different, there's a variety of pros and cons to each of those plan offerings. And what may be desirable to one of our members may not be desirable to another member. We're serving over 100,000 retirees, and so a variety of different personal circumstances, beliefs, and interactions with healthcare and with insurance. So we do have those number of offerings. I do like to describe a little bit about recent history in the PEBB program. So many people were aware that there's a very significant premium increase in Uniform Medical Plan Classic for 2023 that was discussed in the recent board season. There was also about 5 years ago in the summer of 2017, a very large UMP Classic premium increase. And earlier I described some of those differences in subsidies, specifically federal subsidies that are available for other plans and not for UMP. And so there was a general understanding that there was a upward trajectory for UMP Classic premiums that was going to continue because of some of these structural disadvantages. So the state, and when I say the state, there were kind of broader conversations between some parts of the legislature, the governor's office, the healthcare authority. There was a periodic consultation with the PEBB board as well. And that led to a procurement. The state has to do a public procurement because we're spending taxpayer dollars on healthcare and the administration of plans. We did a procurement about 2 or 3 years ago. That led to when we do a procurement, sometimes it can lead to multiple contracts and sometimes it leads to an individual contract. In this instance, that procurement resulted in 2 different entities that were eligible for a contract. That was United Healthcare and Regents for Medicare Advantage plans. We went through negotiations, but we're only able to come to terms with one of them. We could have, there was nothing that prohibited signing 2 contracts. We just weren't able to come to terms with Regents for their offerings to be included in the portfolio. And so that's how we got to where we are today. There was an original recognition back in 2017 that there likely would be a need for additional choices because of concerns about UMP Classic's premium. And those plans, because of those conversations that started in 2017, 2018, resulted in the new UHC plans that were added in 2021. So it is a long ramp. There was an attempt to have even more choice in the portfolio, but when it comes to contract negotiations, there's a lot of different factors, and there simply wasn't agreement with Regents for additional plan offerings. So I don't know how well that answers the question, but that's kind of the operational aspects of running the program and the necessity for public procurements and contract negotiations and implementation timelines. And I like to describe for people that it can easily take 2 to 3 years from the time a decision is made to go down a path to generate a new plan for that new plan to actually come into fruition.
I think that your explanation addresses some of the questions about the cost of the UMP Classic Medicare plan. So I'm going to move on to another question.
Lori, there was one question I know I skipped because I didn't know the answer, and I know Ellen will know the answer. So I just want to,
Okay.
at least I didn't answer it. And so I just want to answer that one. Ellen, can you talk about whether naturopathic drug coverage exists in Advantage plans or not?
Naturopathic drug coverage?
Doctor coverage.
Okay, so there's a difference because generally speaking, supplements are not covered, which may be the result of a naturopathic exam prescribing supplements. Naturopathy as a medical service is covered under the United Healthcare plans. It is a supplemental benefit. Naturopathy does have some limited coverage under Medicare, and therefore it is covered by Permanente to that extent, to the extent that Medicare actually covers it. And that would be true of the Kaiser plans as well.
Perfect. We had a question, if Providence leaves UMP, how will that affect coverage?
So the general answer here is this is one of those things that's kind of every year there are provider negotiations in plans, and every year there are a couple that are extraordinarily challenging. The vast majority of time, people don't even realize that there's tense negotiations going on between a provider and a carrier. A few times, some of those get close to potential end of contract dates, and so the potential for a provider disruption becomes more overt in kind of to both the membership and in the public. But the vast overwhelming majority of times, ultimately an agreement is reached and a provider is maintained. What we do at the Healthcare Authority is with the Uniform Medical Plan in particular, with Regents that is responsible for managing the network. If there is an instance where there is a negotiation is getting close to that contract termination timeline, we will have specific network analyses and we'll address those in those circumstances if they appear. But the vast majority of time, ultimately an agreement is reached. And so we have not had those types of major disruptions that have occurred. So it's there's always a lot of concern that could happen. But my experience kind of in managing the UMP over the last decade and the various capacity I have is that those disruptions ultimately are few and far between.
I know that in the United plans right now, there's some concern with Providence. Providence is apparently running into some difficulties in various areas. And it's important to note that for the current plan year, Providence will continue to see our members as originally covered. They cannot switch in the middle of the year. But going forward, obviously, if they choose to leave the network, that's what happens.
Okay, there's some different questions in chat about hearing aids. And I know you have been specific about not covering what's covered in various plans. Is it best, what would be your answer to those who have asked questions since it impacts a number of RPEC members?
So yes, definitely contact the plan, any plan that you're interested in, and find out about their, not only the kinds of hearing aids that they have, but where you would get hearing aids and what the coverage limits are. They do differ in the different plans. Hearing aids are not covered under Primera Plan G. They are covered by the other plans, but you have to contact the plans themselves to find out where to get them and what any limitations might be.
Okay.
Laurie, the other thing I want to add, because there's this question is, there was recent action by the federal government to make more hearing aids more accessible kind of over the counter. But that deregulatory environment, if you will, doesn't preclude plan coverage for other higher end medically necessary. It kind of opens accessibility for general hearing aids and maybe a broader part of the population to access hearing aids, especially for varying degrees of hearing loss. But there is still a benefit on hearing aids. And I would also say with that kind of deregulation of part of the hearing aid market and a move towards kind of additional private sector opportunities for hearing aids, that will be a landscape that evolves for probably several years. And so there continues to be a need and the existence of a benefit within insurance plans.
And those over-the-counter hearing aids are limited to people who have mild to moderate hearing loss. So it's really important to get a hearing test and find out how severe your hearing loss might be, because an over-the-counter instrument may not be sufficient to address your concerns.
Okay, thank you. Elliot asked, will UMP still use the VHS preferred provider network in 2023? And if you could please explain what VHS is to our participants who are in the webinar today.
Ellen?
So VHS is the vision provider. All of the PEBB plans have vision covered under the medical part of the plan. We do not have standalone vision plans in PEBB. The VHS network is the network that Regents chose for their vision provider, and I'm going to leave it up to Dave as to what happens. I'm not an expert on UMP.
I have to admit, I was reading the next couple of questions already to start to think about who was answering them, so I don't know what you punted to me, Ellen. I apologize.
Will UMP, yes, will UMP continue to use VHS in 2023, and what does that mean for members?
Yes, and I just want to clarify, I think it's VSP instead of VHS. I think I was thrown off by that as well. And so, yes,
I
that is
think it is.
continued
It's
to be
the,
used.
Is that the
Yeah.
vision coverage?
Yeah, vision coverage, it's vision service provider, I think is what their company acronym stands for, but it's VSP as in Paul, or provider.
So that will continue in 23. Vision coverage will continue to be part of UMP?
Yes.
vision coverage is and always will be part of the PEBB medical plans. So there's no change in that. All of the plans have vision coverage. Whether they do it through themselves or another network really depends on the plan itself.
But VSP will continue to be used as the provider network for UMP.
And vision is limited under Premera Plan G because it's only for Medicare approved vision services.
Okay, I'm kind of working my way through this. Phil, his comment is the comparisons between UMP and the other providers is very informative, but missing from this are the levels of customer satisfaction. How is this measured and how do we compare plans? And then he goes on to say delaying service, lengthy appeals seem to be common and can be fatal in nature for the vulnerable elder seniors least able to contest and most physically unable to survive the delay in service. And that last comment relates to the Medicare Advantage plans. Any suggestions that you have for our PEC members regarding the evaluation of these plans based on service and satisfaction of their users?
So all of the plans have what are called CAP surveys, which is, I think, customer accountability of health plan satisfaction. And the CAP surveys is one way that this gets measured, and it's pretty much the same across all of the carriers. So that's a comparison that makes some sense. But generally speaking, all of the different requirements, timelines are different, and it's hard to make a comparison plan by plan. If you have specific concerns about what the limits are or the rate of approvals, et cetera, I would suggest calling the plans.
Okay, thank you. So just a thank you for the presentation today from member Amy, and her suggestion to make future open enrollment decisions would recommend developing an automated walkthrough decision choice tool that could be available for the 2024 open enrollment, something like a turbo PEBB. I don't know what that is. This could include criteria with future changes to UMP Classic, other plans, and federal legislation provisions and geographic limitations. So that was just a suggestion offered. More questions about hearing aids and coverage?
Lori, I
let's
do
see.
want to give a little bit of insight to the I think Turbo PEP is kind of being an analogy to TurboTax. I think that is like kind of an automated tool. I did want to describe, we do have some comparison walkthrough mechanisms on the PEB website. And so we might want to follow up and have that something that RPEC could share about the existing resources. I will say that an IT project of that's like being described here, would require specific investment from the legislature and a significant amount of oversight, and it would have to be HIPAA compliant. And so there is a very long path towards that. At HCA right now with the PEBB program, one of our biggest focuses is trying to modernize our eligibility, enrollment, and billing platform, which dates back to the 1970s and has required significant investment from the legislatures. We're hopeful to get away from so much paper-based reliance, though we would never completely eliminate paper. And in some instances, federal law requires a paper form to come in, but we're kind of right now focused on the ability to do online enrollments, and modernizing our existing platforms. But there are some tools that we can share that exist today on our website that we'll get to you, Lori, for hopefully pushing out to RPAC members.
Perfect. Thank you. A question here. If the bid was 2 to 3 years ago for Medicare Advantage plans, shouldn't it be revisited now? Can the HCA use the full bargaining power of all covered retirees and current employees to get the best rate? And what I would just mention to Nancy is that we have also, with organized labor, asked HCA to explore additional government self-insured plans. So with that kind of as context, Dave, do you want to field that question?
Yeah, and in the chat, this was Nancy had asked if there were the possibility for Regions Medicare Advantage plans, and I had indicated a little bit ago in a verbal answer as well that Regions was a successful bidder, but we could not come to contract terms with them. So there are a couple different pieces here, and I unfortunately can't publicly get into why we couldn't get to an ultimate agreement with Regions, but there is not a change in circumstances in the last 2 to 3 years that suggests that there would be any different outcome. If we were to do another procurement today, we would have to do another procurement. And again, the timelines for that would be 2 to 3 years out from the time that a procurement starts to a new plan. But the circumstances that led to inability to reach contractual terms is not something that the circumstances have changed that would suggest a different outcome. And when we do procurements, we are pulling the entirety of our market basket, as Ellen likes to describe, to get the best deal for retirees and current employees. And the population for PEBB has not substantially changed in the last 2 to 3 years. It always grows a couple of thousand each year, but the difference between 380,000 and 385,000 isn't a noticeable enough difference to have significant additional purchasing power. And the other piece that carriers know about the state is we tend to enter long contractual relationships. And part of why we do that, they can be anywhere from 5 to 10 years in length for our contracts. And that's so that carriers really do know that they need to put their best foot forward in our procurements, because if they aren't willing to engage and reach contractual agreements, they know that they might not have an opportunity again for 5 or even 10 years to get into the market. And it really helps drive down costs and make those procurements as competitive as possible.
So thank you. Our member Matt has asked a few times about where to go for help. I think it would be beneficial if you could cover again the kinds of questions that your staff answer within the call center, the kinds of questions that might be best addressed by Hca, and the types of questions that should go directly to plans, because this is a very complex landscape.
So the slide that's currently up indicates the kinds of information that you can get from the customer service line. And that includes eligibility or finding out about forms or deadlines. It's best if you have specific questions about coverage or drugs or specific medical situations that you call the plans themselves. And again, the plan numbers will be on the recording and also in the materials. They're included a couple of times. And then I just wanted to make a note on the PEBB portfolio. We also have dental coverage, which is available to Medicare retirees. And I'm not going to go into the specifics, but it is separate from the medical plans. They are not included in medical plans, but PEBB does offer dental coverage as well. The kinds of questions that you should look to the plans to answer are things like, is my provider covered? Is my prescription drug covered? At what tier is my prescription drug covered? What are the copays I can expect to pay? What facilities are included? If you live out of state and you want to go to a specific hospital, it's worth finding out if the hospital is included. So all of those things go to, coverage, costs, your comfort with the plan. The more information you get, the more comfortable you can be, and the convenience. In terms of Hcba, which is the statewide health insurance benefit advisors, those are volunteers who work with the Office of the Insurance Commissioner. They generally give information about the individual market plans. So it's very important to remember, if you choose an individual market plan, you run the risk of losing your PEBB eligibility. While Hcba volunteers can give some cursory information about the PEBB plans, they know the general offerings under the PEBB portfolio. They don't really have specific information. And so again, the plans would be the best place to go.
And I just want to add one piece is we sometimes get questions coming up more often lately is the question is, why doesn't HCA and PEBB coordinate more with Hcba? We do have direct relationships and coordinate with Hcba. They just have to balance different interests that they have. There's no prohibition on them talking about PEBB. We do provide information about PEBB benefits, and many folks who volunteered at Hcba have formerly been state employees and are very familiar with PEBB benefits, and they may be PEBB retirees themselves. But Hcba is a good point for being able to help compare and contrast and understand non-PEBB options to then compare with PEBB options. But again, Ellen's right. It's very important to think carefully and understand if you might lose eligibility for PEBB if you enroll in an individual market plan. Laurie, I also want to highlight the last question that I see right here that just popped up. Will there be in-person benefit fairs again? Yes. Yes, there will be. We did not have any in fall of 2020 or 2021 related to COVID, but actually in November, there are going to be in-person benefit fairs. There are 8 that are set up around the state. We'll send some the schedule so that Laurie can include that, or RPEC could include that for sending out. But there's the first week in November are Eastern Washington locations, and the second week in November are Western Washington locations. So we're dipping our toe back into in-person benefits fairs. It's kind of a limited scope. There's 8 of them. We used to do a few more than 8. I'm hoping that in 2023 we'll have more than 8, or we'll be rotating within regions for access. But we are bringing back in-person benefit fairs, and you should also see that schedule in your PEBB retiree newsletter that gets dropped in the mail later this week and should be arriving in mailboxes in the next 1 to 2 weeks.
And I will be at the PEBB benefit fairs in Eastern Washington. So the first week in November, look for me in Eastern Washington.
I also want to say that, Christine, I see your question about ACO REACH. I think we'll have to come up with a statement that we can send back for Laurie to send out. I'm worried about getting that one wrong off the cuff, but I wanted to acknowledge, because you diligent in wanting us to answer that question, and I didn't want you to think that we didn't see it. I think we're just going to have to do some follow-up on it. Let's see.
Laurie, you might be on mute.
Thank you. I've got the chat open. So thank you for covering Christine's question. I was going to handle that next. There's another one here. If you could just highlight again the broad steps for making changes to your medical plans.
Ellen, you want to cover that?
Sure. So you have to fill out form. It depends on what medical plan you're in and what changes you're making, but at a very minimum, fill out form AOE. So form A-OE. I think it would be best to call the customer service line and ask about your specific situation and what changes you want to make, because it depends on if you're going from a Medicare Advantage plan to something else, or if you're going from UMP. So I think you need to get your specific questions answered. And again, that's 1-800-200-1004.
There was a question here. Okay. I may be reading into this one question, but if a person makes a plan change, is the dental plan coverage independent of the medical coverage?
Yes, so the dental plans are separate. They have a separate premium, which actually, Lori, reminds me of a point I wanted to make. You have to pay your Part B premium for Medicare Part B separately from the premiums that we discussed here for the PEBB plans. So your Part B is in addition to that. And then dental plans are completely separate. So you can change your dental coverage during OE, or you can pick up dental coverage if you didn't have it in OE, or you can, OE is open enrollment, or you can drop dental coverage if you so choose.
And Ellen, can you speak to whether dental premiums are changing this year? I can't remember.
I can't remember off the top of my head and don't want to make a statement, so I will research and get back to Lori on it.
Okay. I think we've covered everything that has come in chat. And so what I'd like to do is see if there's any other lingering
Lori.
questions.
Nope, I'm muted.
Are there any other lingering questions? Any hands that are raised?
Lori, we had.
Alyssa? Alyssa, do you want to cover the additional question? I'm not seeing it.
Yeah, can everyone hear me? There we go. My mic wasn't working. Yeah, we have one question. Can just my husband drop out if I am the insured and covering both of us?
If you are the subscriber on the account and your husband is a dependent, you know, you kind of control whether your spouse is on your account or not. That's the best way to say it. You're the subscriber on the account and you have the authority related to any dependents.
And Lori, if I may, I'd just like to remind folks that there's an email that's up that's showing right now, HCA PEBB Medicare at hca.wa.gov. So if you have any general questions, please use that HCA PEBB Medicare email address. Thank you.
We had another question that came into chat. Will there be a way very soon for us to pay our premiums online versus via mail?
At this point, there aren't payment options, expansion options. So I want to highlight what ways there are today. You can mail by check. You can also sign up for pension deduct to have, if you receive a pension payment from the Department of Retirement Systems, you can have your premium auto deducted and sent to the Healthcare Authority from the Department of Retirement Systems. And you can also enroll in electronic debit services to have the amount taken directly from your bank account. But we don't have a process right now to set up a one-time online transfer at this point. And Lori, I want to go back. I found the dental premium question answer. So for 2023, if you're in the Willamette Dental Group plan, there's no change. If you're in the Uniform Dental plan, you're going to see a drop of 8 cents per month. And if you're in the Delta Care plan, you'll see an increase of $1.97 a month.
Okay, another question popped in about the listening sessions regarding the UMP Classic Medicare plan. So I'll address those very quickly. For our RPEC members, you're aware that RPEC formed and is leading the PEBB Medicare Coalition. We have been meeting with Ellen and Dave and also Jane, who joined our webinar today on, I think it's about every 2.5, 3 weeks to talk about a listening sessions and public forums. We're working through that process now. We've discussed holding public forums and listening sessions through 2023. And as I have put in chat, HCA has made a public commitment to not terminate the UMP Classic Medicare plan. So I don't know if HCA would like to address this as well, but I will keep you informed about our work with HCA through the monthly member letter that I put out via email and share with our RPEC chapter leaders. It's also embedded in your chapter newsletters. And when there's information of note, please know that I'll be sure to put that in our member newsletter, which is produced 4 times a year and comes to you through US mail.
Lori, I think you covered things well. I just also, before more people leave, want to highlight open enrollment for the PEBB program is the month of November, November 1st through 11/59 on November 30th. That's different than the federal open enrollment period, which goes into the early part of December. Please remember that PEBB's annual open enrollment ends at 11:59 p.m. on November 30th.
And that means that HCA has to receive your forms by 11:59 on November 30th.
And we will emphasize this as well in the materials that we send out and on our website. So thank you for bringing that back around. We are at 12, almost 12:15. Are there any final questions for Dave and the staff at HCA?
This is Elliot. I do see a question in the chat.
I was just going to say, Lisa, I think the best thing would be to call 1-800-200-1004 to find out exactly how you can do your enrollment when you're awaiting your specific confirmation on Medicare. So I think my customer service team would be the best to answer that question.
Jose, do you have a question?
I do have a question. I noticed that when you were saying out of country travel, if you had services, that you would pay for the service and then submit a reimbursement. What about travel within the United States to another state?
So Jose, the Uniform Medical Plan and the Primera Plan G and the United Healthcare MAPD plans, all of those are national plans. So if you're traveling in the United States, you can see any doctor who accepts Medicare and is willing to accept the plan. If they don't accept the plan, you can pay for services and be reimbursed. But those are nationwide plans.
But do they bill the plan themselves, the providers?
In most cases, they do.
Okay, thank you.
Alyssa, do you see any additional hands raised?
No, I don't see any hands or any more questions.
Okay. All right. Well, we so appreciate the opportunity to learn more about the plans available in 2023. We want to thank Dave and Ellen and the HCA staff for putting this presentation together for us and for setting aside this time to answer our questions and for making this information available. As I've put in chat a couple of times, we will make the PowerPoint available. It was also in chat. We will be posting this as well, the recording, to probably our YouTube channel. And so look for that to be posted in the next day or two, but we'll certainly get the PDF of this PowerPoint up on the website right away. And there's something else coming in chat. I don't see anything else. All right, well, Our PEC members, thank you so much for setting aside this time, and HCA, thank you for the for this opportunity to learn more about the
Mhm.
plans that are available during the month of November for open enrollment for PEB subscribers.
Thank
Have
you,
a
everyone.
have a wonderful day, everyone, and thank you.
Thank you.